Sala, for inviting me to this prestige meeting. It is indeed an honor. So I've been asked to speak on how to get success with same-day implant restorations, and that is exactly the same name as our clinic in Dubai, which is called Same-Day Dental Implants, where we basically treat people with extractions, implants, and teeth all in the same day. And you are most welcome to visit us next time you come through Dubai. It's a clinic that we are very proud of, and we try and make the whole experience as comfortable as possible for the patient. We even provide them with a Rolls-Royce transfer to their hotel or home in true Dubai style. So let's get right into the subject, and please hold tight because we have to go very fast to go through 15 parameters on how to get success. So the first parameter is graft less and table less. So I'm not saying graftless, I'm saying graft less and table less. And so why do we do extensive surgery? We do extensive surgery in order to do bone reduction, which here in the USA is called tabling, or to do bone grafting when we need to create bone. And both these procedures are relatively extensive, and they carry a certain amount of morbidity, increased costs, increased time for the patient, and we do live in a busy world these days where everybody wants to get things done pretty fast. So we try and avoid tabling, and we try and avoid bone grafting as much as possible. And let's just focus a little bit on tabling, which is known as bone reduction, and let's have a look at some rather important problems related to tabling, which we don't like and we do very rarely. We can get depletion of bone. We can land up with a dentoalveolar defect instead of a dental defect. We also get decreased AP spread. And if you have a look here, if we don't table, our AP spread is from here to here. If we land up tabling, look how our AP spread is minimizing. That's terrible. So if we have a dental defect, let's, if possible, stick with a dental defect and not go to a dentoalveolar defect. So on the left side, on the right side of the patient, we have a dental defect, which means the teeth are missing. So if possible, let's just give the patient teeth. On the other side, on the patient's left side, we have a dentoalveolar defect or a composite defect. So in that case, we have to replace the teeth and the lost alveolar bone and soft tissue. And this brings us to a very important issue, which is called the transition line. If the patient smiles and the lip rises high enough so that you can see the transition between the patient's pink and the prosthetic pink. So if we have a look here, this is the patient's pink up here, the lighter color, and the redder color is the prosthesis pink. You're not supposed to see that when the patient smiles. If you see that, it's an aesthetic disaster. So that's not negotiable. Then you have to table. That's the only time you have to table, is when the transition line is visible. If, on the other hand, the patient smiles like this, there's no need to table. And of course, if it's a dental-only defect, there also is no need to table. So the question is, when must you table? And the answer is, you must table when the transition line is visible at rest or when smiling. That's it. That's the only time you need to table. This is, in most cases, by far the majority of cases, unnecessary. We don't need to do this. I mean, have a look at this video. We don't need to do this. There are cases that it's indicated, I accept that, but in most cases you don't need to do this. We don't believe that this is the correct thing to do. Also, if you do that, it causes a horizontal cantilever with ridge lapping instead of nice convex profile for cleaning. So you land up with this ridge lapping. Tabling results in this ridge lapping type of situation, which is a disaster for the patient to clean. Look what's underneath there. So what should we do about avoiding? What should we do about avoiding? How can we avoid tabling, and how can we avoid extensive grafting? Well, we can avoid tabling by using site-specific implants with built-in angles, no need for space-consuming angled abutments. A 30-degree angled abutment needs 4 millimeters of space. So we want to decrease the amount of prosthetic space necessary by using these implants, and also by using metal ceramic restorations, in other words, PFM, instead of metal acrylic restorations. And we can decrease the amount of bone grafting by using tilted implants, angled implants, immediate molar replacement implants. Have a look at this. This is interesting. On the one side, you see a PFM restoration. You need 9 millimeters for that. On the other side, you see a metal resin or metal acrylic restoration. You need 18 millimeters of prosthetic space for that. It's almost a centimeter more. So treat the patient with a PFM. Then you don't need to table. The philosophy is mold the prosthesis to the patient and not the patient to the prosthesis. So look at this prosthesis here. It's a dental defect posteriorly. It's a dental alveolar defect in the front. So we mold the prosthesis to the patient. If we use metal ceramic restorations, in other words, PFM, we can use them for dental-only defects. We can use them for dental alveolar defects. We can use them for combination defects. We can avoid unnecessary tabling. If we want to use zirconia, it's a great material, we're indicated. We need a little bit more space than PFM. We need more like 10 to 11 millimeters. We definitely don't need 18 millimeters, unnecessary. This is a zirconia restoration. And now we get on to the second point, and that's flap-less. I'm not saying flapless. We do flap sometimes, of course we do, but we try and flap as less as possible, and that is in order to preserve the blood supply. Because when we extract teeth, the blood supply from the PDL is gone. If we raise the flap as well, then we get the blood supply from the periosteum interrupted. So we want to flap as less as possible. If this is a case that needs a maxillary clearance, we treat the patient flapless, PFM, no tabling, no grafting. This is the pre-op panoramic. This is a 3-year follow-up. And have a look at this. No need to table. Not every case needs tabling. Sure, there are some cases that need tabling, but we can avoid it in the majority of cases. This is a simple case that needs 2 implants and a few veneers, and the plan is to place 2 implants in each lateral, congenitally missing lateral incisor area. And one of our younger associates said he wanted to do the one side and I would do the other side. I said, no problem. And I did the tooth number 10 flapless, and he did tooth number 7 raising a small flap. So this is our patient. And after about 5 to 6 months, once the veneers were completed, and at the recall, have a look at the papilla around tooth number 7 where a flap was raised as compared to tooth number 9 where there was no flap. I mean, there's an obvious difference. Look at that. So the benefit of not raising the flap where possible is great. This is a good article by Thomas Albrechtsen and Anne Wennerberg on the advantages and disadvantages of flapless. Basically, the advantages are less marginal bone loss, less soft tissue bone loss, less soft tissue loss, more rapid healing. And the disadvantages, if you're not careful, you can get thermal damage, you can get risk of perforation, and you can't see very well. Of course, if you have a certain amount of experience, that doesn't apply. You can quite easily do a flapless case like this without those problems. Now, next point is the number X, all on X. What is the right number? Is it 3, 4, 5, 6, 10, 12, whatever? And if you read Skullock, Bo Ranget, and John Bronski, you'll see that the load-bearing capacity of a prosthesis is determined not only by the number of implants, but more important by the distribution of implants. Distributions means AP spread. So the most important implants here are actually the front ones and the very back ones. The in-between ones are not so important. So the distribution is more important. If you have a look at a big table actually needs 4 legs, doesn't need 12 legs in a straight line. It needs 4 well-positioned legs. So it's the spread that's more important than the number. I mean, this patient with 12 implants in the top and 5 implants in the bottom, I think that on the top it's over-treatment, too many implants, unnecessary. If the spread is good, you can even get away, I think, this is just my personal experience, I'm just sharing some cases with you, with 3 implants. This is one of my all-on-3 10-year follow-up. It seems that if the spread is fine, there's no problem. This is another all-on-3 in the mandible, 3-year follow-up. Also seems okay. Of course, this isn't evidence-based. I'm just sharing a few thoughts with you. What is evidence-based is the all-on-4. Certainly in the mandible, it's well documented and it's backed up by enough evidence. So it seems that all-on-4 is okay. Of course, if you want to put 5 or 6 implants, it's also okay. This is a case in the lower jaw. We have all-on-4 8-year follow-up. We even went to 6 cantilevers here, 3 on each side. Typically, we restrict our cantilevers to 2 cantilevers on each side, but in some cases we do have 3 and it works well. And if you want to read more about cantilevers, George Romanes supports the use of cantilevers to reduce costs and healing time in this publication in JOMI, where he has many cases with over 10-year follow-up. It seems that 2 cantilevers in a full arch is no problem. Next thing is you should have adequate bone and soft attached keratinized tissue. So the hard tissue, the rule is 2 millimeters. You must have 2 millimeters of bone around the implant, in particular on the facial or the buccal. And this is the classic article by Spray in the year 2000, that's 19 years ago, that showed the critical bone thickness of 2 millimeter. If you have less than 2 millimeter, you risk having bone loss and peri-implantitis. So you must have 2 millimeters of bone. Less than 2, not good enough. If you have less than 2, you risk having this scenario. You risk having bone loss and having peri-implantitis. And that's where osseodensification is a big help, preventing that bone loss, preserving the bone, expanding the bone. If you don't use Versah and if you stay too buccal, this is what happens. You get loss of buccal plate, you get the implant shining through, and to follow that, you're going to get recession, and it's a disaster. You need to also have enough attached keratinized tissue to protect the implant. This is what you want to have in terms of keratinized tissue. Then the next parameter is the position of the implant. Now, the position of the implant is 3D. We're talking about a 3D position. Front to back, in other words, facial to palatal, buccal to palatal. That's the one axis. The other axis is the mesiodistal, and the other axis is the coronal apical, or apical coronal. So, you must stay away from the buccal plate. You must be adequately towards the palate in order to prevent this disaster. This is one of my cases. I did 5 years ago. I redid it 3 years ago. This is a disaster. You must stay away. Of course, this was before Versah. Maybe if I had used Versah, maybe I would have not had this problem. But you must stay away. Secondly, mesiodistal. Not all teeth are the same distance between each other. The molars, molar to molar, is different from premolar to premolar. This is a chart that comes from a good dental anatomy book. Highly recommended. I have one in each office because I'll forget the numbers. So if I'm going first premolar to first molar, it's 7 plus 9 is 16 millimeters. I now got to be 16 millimeters apart. This is another nice chart to use. Teeth and implants should not be the same interproximal distance right through the arch. Molar to molar is, in the lower jaw is almost 11 millimeters. Premolar to premolar is 7. So we've got to respect those distances. And if you need, you can use a caliper. A caliper is a very useful tool in implant dentistry to position the implants in the correct position. Then you'll get your access holes right, like you see over there. Next question. How deep should your implant be? Very important question. You know something? It took me almost 20 years to work this out. I kind of knew about the biologic width, but I couldn't quite apply it into implant dentistry. If we take typically lower molar area healed site, posterior mandible healed site, very often the bone, the soft tissues are very thin. How often do you see 1 to 2 millimeters of soft tissues in the back here? Very often. So if you place your implant bone level, like there, and if your soft tissues are 1 to 2 millimeters, 2 months later, you will have 2 millimeters of bone loss around the implant. Why? Because the body wants to reestablish a 4 millimeter biologic width at the expense of exposing some threads on the implant. If, on the other hand, you place your implant deep enough to start off with, in other words, 2 millimeters of soft tissue and another 2 millimeters below the bone is 4 millimeters, 2 months later, yes, you have bone loss, but you haven't had any of the implant exposed. Very important. I wasn't quite aware of that, and that's something that we must bear in mind. So, the biologic width is the 4 millimeter rule. We must place the implant deep enough. If your soft tissues are already 4 millimeters, there's no need to place the implant deeper than bone level. But if your implant, let's say, if your soft tissues are 1 millimeter in thickness, then you must place your implant another 3 millimeters lower, deeper, because you have to allow for 4 millimeters biologic width to be reestablished. So the question is, how deep should you place your implant? Well, the answer is it depends on the soft tissue thickness. It also depends on the emergence profile that you want to develop. And a nice rule is, if you take the gingival zenith of the adjacent teeth, the gingival zenith, the highest part of the gingiva here, and the highest part of the gingiva there, you join them with a line. 4 millimeters up is where your head of your implant should be in order to allow for the emergence profile to be generated. Okay, so this is your 4 millimeter apicocoronal distance, which is necessary for your emergence profile. So this situation here is incorrect because your laboratory will have to create like a little step here, a ledge, because this implant is too shallow, so that's wrong. Whereas this is right, it's deep enough to allow for development of the right emergence profile. The next parameter that helps us a lot is a silicone surgical guide or index. What is that? That is basically a bite registration addition cured silicone, which people use to take bite registration, and we use it to inject around the labial of the teeth, and we use that as a guide to guide us where to place the implants so that we don't place them too buccal, too palatal, too mesial, or too distal. If the teeth are not in the right place, then you should do a wax up and make a guide based on your wax up. Next very important point, do serial extractions. Don't take all the teeth out and then start putting the implants in. That's completely wrong because you lose all the guides, all the beacons that you may have from your adjacent teeth. You lose your vertical dimension, you lose your centric relation. So take one tooth out, put one implant, then take another tooth out, put another implant, you've got your guide, and basically look how nicely the implants have been positioned exactly where the teeth used to be. And before you take the last teeth out, very important, take a bite registration so that you've captured your vertical dimension and your centric relation. The next parameter is primary stability, which is directly related to osseodensification. So you've got to osseodensify your site. In other words, remove less, move the bone more to get primary stability, because primary stability is your code to immediate loading. Because primary stability prevents micromotion. It prevents the implant exceeding the threshold of about 100 to 150 microns of micromotion. So if we can prevent that with primary stability, we can load our cases immediately and have just as good success as delayed loading. But we have to have primary stability, and that's where osseodensification comes into the game. As Salah says, do not remove the bone, just move it. Now, how can we get good primary stability? If we look at these two columns, this column here is the thread design, the implant taper, the implant length, the implant width, diameter. Those are factors that affect primary stability, but you can't really change those factors. Once you say, I want to put an 11 millimeter implant, 4 millimeter diameter, that's the implant you've chosen. You can't do much more about that. But on this side, you can. You can densify the bone. You're in control of this side. You can densify the bone. You can under-prepare. You can engage the cortex, either nasal or sinus cortex, or whichever cortex you want to engage to get more primary stability. And as we all know, the magic of osseodensification lies in the counterclockwise drilling, which compacts the bone and gives us this increased bone density, which in turn allows us to have good primary stability, which in turn allows us to give teeth on the same day with immediate loading. So does extreme torque cause bone necrosis? From what I can see, from our personal experience, and from what I see in the literature, no. Up to 176 Newton centimeter, work done by Kayat and his team, no bone necrosis. And as we all know, the main guy with primary stability is Paolo Trisi. And in this publication, sheep study, he placed 4 implants on this side of the mandible of a sheep, 4 implants on this side. I think he used 10 sheep. One side, 10 Newton centimeter, other side, 110 Newton centimeter. Histologically, no bone necrosis. So we don't get bone necrosis. The next way of getting the success we want is using site-specific implants. What do we mean by site-specific implants? They're implants that are more suitable or more specific for certain sites. For example, immediate molar replacement, angle the implants away from the sinus to use existing bone, thin implants, wide implants, narrow implants. That's what we mean by site-specific implants. And here we see the beautiful synergy between site-specific implants and Versah osseodensification, where we can use a molar site and we can do a subcrestal sinus lift using Versah to engage and push up the floor of the sinus, thereby avoiding a massive sinus lift. Look at this big sinus. So we've used a wide diameter implant, immediate molar implant. We've used a severely tilted implant with a built-in angle to avoid the sinus, and we've been able to treat this patient with implants and teeth all in the same day. This is another case where the patient needs to have the upper left molar area addressed, has less than 5 millimeters of bone, so we basically want to do a protocol 2 sinus lift, subcrestal sinus lift procedure. You can see the allograft that we've placed in this area, and with lifting the sinus and with densifying the bone, because we're not only lifting the sinus with the Versah, we're densifying the bone, we managed to get excellent primary stability in the region of 90 centimeter. Of course, there's no reason not to load these immediately with that kind of stability, in particular if you join them. We've joined them with 2 multi-unit abutments, and the patient gets their teeth within 3 or 4 days. The permanent teeth. These are the permanent teeth. What about narrow sites? Again, with Versah osseodensification, if we meet certain requirements, like having at least a 1-to-1 cancellous cortical ratio and having 2 millimeters of cancellous bone, we can expand a narrow site, and together with narrow implants, by narrow we mean 3 millimeter diameter and 3.25 millimeter diameter implants, we can place implants without bone grafting, and we can load the patient, this case, immediately. So this is a case, a young lady, believe it or not, in her 20s, who was about to get married but had no teeth, and she needed to get teeth fast. What we did here is we placed some 3 millimeter diameter implants together with some 3.25 millimeters at the end, and we gave this patient her provisional fixed teeth on the same day and permanent teeth in 1 week. So this case was completed in 1 week. Then we have angled implants, which means they are implants with built-in angles of either 12, 24, or 36 degrees, and they are the so-called co-axis implants. So the implant has an angle correction within the implant, subcrestal angle correction. So we don't need to use angled abutments, which occupy 4 millimeters of space if it's a 30-degree abutment, or 3 millimeters of space if it's a 17-degree abutment. This is one of the older cases. This is a 12-year follow-up. It's a 24-degree implant. There's your sinus. And we can apply it also to full arch cases like this case, where we've used 12, 24, and 36 degrees to avoid the sinus and complete the case within 7 days with the permanent teeth. As far as tilting of implants is concerned, this is one of the older publications, 20 years ago, 19 years ago. There are lots of publications out supporting the use of tilted implants. What about wide implants? These wide implants were designed initially to address the immediate molar replacement. In other words, we want to take out a molar and we want to place an implant at the same time, provided we have intact buccal plate, we have a thick biotype, good case selection, in order to avoid socket grafting and delay in the treatment protocol. So this was the original idea of these very wide implants. The idea was extended to use them in combination with other site-specific implants to address the full arch case and avoid big augmentation procedures. In combination with Versah, we can also lift the sinus floor where indicated. This is another one that's been lifted up very nicely. The sinus was here. We've lifted it up. And just to let you know, the 6 millimeter diameter, 7, 8, and 9 millimeter diameter wide implants are available in the USA. The 10 millimeter is not available in the USA yet. It's only available in Europe and certain other countries. And there are a dozen or so publications on this topic. And this is the latest one, which shows 580 clinical cases, 10-year follow-up with 95.7% survival rate. So it's a nice extra tool, site-specific implant to use, and I'm using that very much in combination with subcrestal sinus lift using the osseodensification, the Versah. Then we want everything screw retained, everything, not negotiable. We don't do cement retained, we do everything screw retained. We need to get our access hole 1 millimeter palatal to the incisal edge. And if we look at this publication, this research by Joe Kahn, where 81% of cases of anterior teeth, the relationship of the root to the ridge looks like this. So we have quite a lot of palatal bone. So most of our cases look like this, but of course we need a cone beam to address each specific case. And the way we do it is as follows. Our starting point is about 2 millimeters away from the apex on the palatal wall. That's the starting point. We aim for the incisal edge. We always aim for the incisal edge. And if we aim for the incisal edge with a 12-degree coaxial implant, an implant that's got a built-in angle, we get screw retention. So we start off with the pilot, we carry on with the Versah, and we land up with a 12-degree subcrestal angle correction so that we can get our access hole through the cingulum. Why am I insisting on screw retained? The reason I'm insisting on screw retained is because, according to Wilson, in an article he published in 2009, 80% of peri-implantitis cases are secondary to subgingival cement that has been left behind. That's one publication. That may not be the whole truth, but certainly it's a significant number. So we don't like cement. And this is a newsletter that comes out every 4 months from the Academy of Osseointegration. And there's a section called Dollars and Cents. And a guy by the name of Bruce Barr writes in there. And his advice, if you want to make dollars and cents out of implants, advice number 1 is, where feasible, use screw retained. And the other 9 points are what you must do if you happen to do cemented in order to stay out of trouble. Isn't that interesting? So, screw retained. It's also very interesting that some of the bigger players of the industry are now saying cement belongs to yesterday. And it's interesting, before they were saying CB&I, crown, bridge, and implants, cemented. Now they say cement belongs to yesterday. And if we have a look at the literature, there's lots of literature. This is the Harvard Classic publication by H.P. Weber. And they say in this 3-year prospective study that peri-implant soft tissues respond more favorably to screw-retained crowns when compared to cement-retained crowns. So that's interesting. Basically, we want them to respond like this, with screw-retained, and like this. And the whole procedure with screw-retained prosthesis is so much friendlier. It's fast. You get faster laboratory procedures, faster clinical procedures, retrievability, predictability, easier to execute, no excess cement to deal with. The next item, number 11, is use one multi-unit abutment one time when doing multiple implants. And for the first 10 years of doing implants, we were doing them at implant level. We were not placing abutments. And we found a few years later, 5 to 10 years later, unexpected bone loss. And then we started placing abutments at the time of surgery, the one abutment, one time concept. And we found almost no bone loss if you place the abutment at time of surgery in a clean, controlled environment and torque it down to 45 and never remove it. And we see there's adequate literature to support the one abutment one time. And not only that, we want to use one straight abutment one time. We don't want to use 17 or 30 degree angled abutments. We want the angle to be corrected in the implant. So we avoid the space, the prosthetic space occupying abutments. And the classic one is by Abrahamson and Berglund and Lindy. That was the dog study of connecting and disconnecting and connecting and disconnecting the abutments. And they found that if they had multiple connections and disconnections, they had soft tissue recession and bone loss, as opposed to the abutments that were never removed. And similar feedback from the Italian group, the Gidi and Piatelli, that one abutment one time is the way to avoid soft tissue and bone loss. And this is also an excellent meta-analysis which shows a significant difference between, this is the final abutment placement, and that's the multiple abutment placement. They found a significant difference between the marginal bone levels between that group with final abutment placement and the multiple abutment placement, and that's a meta-analysis. And this is what we do basically. At the time of surgery, we place the abutments and we torque them at the same time. Then, why don't I like these angled abutments? A, they take a lot of space, 3 to 4 millimeters. B, there's a section here in the thread where the prosthetic screw goes that is very thin, and that breaks open sometimes. We far prefer to have the angle corrected in the implant and then place a 1 millimeter straight abutment. Let alone the cumbersome procedure of placing these angled abutments, which have 12 positions. They have 12 different positions or configurations, especially if you're trying to place it in the back of the mouth. It can be difficult and annoying. What do we do with these cases? We give them temporaries on the same day, not the greatest looking temps, but they're only for 5 to 7 days. We give them temporaries on the same day, and we give them permanent teeth 1 week later. This is a very nice publication from the University of Georgia, supporting our cross-arch, rigid, and passive fixation. We believe that by placing the permanent prosthesis, which of course has a rigid metal framework or zirconia framework, by placing a rigid framework, we are protecting the implant. What they did is they placed 5 implants with very good primary stability. They quickly made the permanent prosthesis in 2 days. They then removed the middle implant 2 days later. And they connected a thinner implant to the final prosthesis. So they placed 5 implants, very good stability, made the permanent prosthesis within 2 days, came back 2 days later, removed this middle implant, connected a much thinner implant that would be floating there otherwise, placed it back into its socket, screwed it down to the other implants, let it heal for 4 months, came back, and they found it was integrated. So that supports the concept that if you have one of your middle implants not having such great stability, you can still get away with it, provided you rigidly splint it. So this is what we use. We use frameworks like this, and we connect it. The next thing is, point number 14, is we must use, or we must teach our patients how to clean their teeth. Very, very important. We teach them with all the available gadgets and cleaning aids. And this particular floss, which is like super floss, but better because it has a nylon butler needle attached to a nice soft piece of thread, is very useful. And we must make our prosthesis cleansable with convex profiles and not ridge lapping. The design of the prosthesis is important. We don't want this. This is unacceptable. This is the X-floss that I was talking about with the nylon threader. The patient doesn't get frustrated because he can thread it easily and he can clean. And then your tissues will look like this if you take all those factors into consideration. Now, the final thing is that sometimes we have to reline the prosthesis after 2 months. Look at this patient. He got his temporaries the same day. A week later, he gets his permanent teeth. Looks pretty good. And 2 months later, he comes back, and what do we have? We have a significant gap under the prosthesis, under the pontic. Not the end of the world. We remove it, take a low viscosity impression, and within a few hours, the laboratory, our in-house laboratory, has made a new G mask on the old model, just a new G mask, low fusion porcelain, goes back in the mouth the same day. And this is the patient 3 years later. Now, I'm going to spend time a little bit on this case because it shows how we can use Versah to optimize a challenging case. Not that we only use it for challenging cases. We use Versah for almost all cases, but this is an interesting, challenging case. So this lady needs a clearance, and she needs all on 4 upper and all on 4 lower. We have some danger zones, zone number 3 and 14 in USA terms. Yes, zone number 3 over here, and zone number 14, we have some rather narrow islands of bone, 3 and 14. So we have one chance to get it right, and we want to preserve that bone, we want to expand it a little bit, and we want to densify it. This is where Versah is king, to preserve that narrow island of bone there. We don't have the luxury of lots of bone to play with. This is the CBCT, upper and lower, and let's have a look. So let's design the case. We want an implant in the first molar on the left. We want an implant in the canine on the left, canine on the right, and first molar on the right. And just an outline of the available bone. This is that island of bone that I was talking about. This is our denser pilot drill, 1.7. This is the 2.3 counterclockwise, the 3 counterclockwise, 1,200. Lots of irrigation, very important, and the irrigation is chilled. We place our implant. This is a 4 millimeter diameter implant. Okay, let's see, over 45 Newton centimeter. Implant placed. Let's go to the canine. This is our 1.7 pilot drill clockwise. Then we go to the 2.3 counterclockwise, 1,200 revs, the classic protocol. This case is done flapless. In the extraction site, as Salah said, there's enough room for the irrigation to go all the way down. Look at the irrigation. It's going right into that socket. There's no problem. This is our 5 millimeter diameter implant with a 12-degree angle correction. So this is a nice clinical solution to get everything screw retained. The engine stopped at 80 Newton centimeter. This is a torque wrench that goes up to 100. And there you go. Thanks to Versah. Let's go to the molar on the other side. 1.7 pilot drill. Use a periodontal probe, very important to assess whether I've perforated somewhere, whether I'm in the sinus, whether I'm too buccal. Periodontal probe is an extension. It's an extension of your hand. When doing implant dentistry, you can feel where you are. It's a big help, a periodontal probe. .3 counterclockwise, 1,200 revs per minute. Place the implant. You'll notice there are 2 black lines on that fixture mount, very important because the one is 3 millimeters away from the other, so I can determine the depth that I want the implant to go in. I'm using an implant inserter. It's like a baby Zygomatic implant. And look at the torque. 100 Newton centimeter. Okay, so we got the idea that by using osseodensification, we can preserve, we can densify, we verify the position with our key, our surgical guide. Before we take these teeth out, we take our bite registration before we lose very vital information. That's why we believe not to remove all the teeth from the beginning. So this is our bite registration. And then we remove the remaining teeth, replace the remaining implants. And this is the case. Same day temporaries, we managed to get 100 Newton centimeter on all these implants, a total of 400 Newton on the lower jaw, 370 in the upper. And I hope I don't get moaned for going to 100 Newton centimeter, but this is what happened. Not my fault. And you can see the nice osseodensification that allowed us to get these values. If we have a look at the before and after scans, we can see the implants have been positioned nicely within the envelope, away from the buccal crests. This is the before and after. I'm going to quickly go through the following cases because I want to get to the zygoma, and I see I've only have 12 minutes left. This is a case that does need tabling. Why does it need tabling? Because the transition line is irregular. It's up there, it's down here, it looks anesthetic. So here we need to do some tabling in order to get a nice result. So what we do is we remove those teeth, we table that area, we place 6 implants in the upper jaw, 4 in the lower, and the case is complete. This is a more challenging case. We have some islands of bone here, tuberosities. This is a combination type syndrome. If you have a look at the patient, when she's biting, you can actually choose your vertical dimension. So this is a more challenging case. And if we have a look at the available bone, the one way of treating this case is with a quad zygoma. And another way, a less invasive way, is by using site-specific implants in these areas where we have bone, immediate molar, angled, and this is the case complete 1 month later. We used a combination of tooth only and dentoalveolar prosthesis, and this is our patient. Another case, this case we cleared extremely soft bone. You can see it from the x-ray, extremely, not type 4, type 44. This is where Versah comes in big time, and this is the end result. Now, this is, I think, the highlight of my presentation, and we're going to zygoma cases. For decades, zygoma clinicians have realized that the system needs optimization. It needs, they always looked for a way of doing it better. Doing it better at 3 levels. Level number 1, the drill. The zygoma drill is totally inappropriate, very barbaric, a lot of chatter, not nice to use, removes a lot of bone. So the one level where the zygoma has to be optimized is the drilling. And Sala and Versah have very elegantly addressed this issue and have come up with a solution. The second level where the zygoma has to be optimized is the implant itself, and I'll show you in a moment. And the third level is the whole procedure. So what's so special about these zygoma denser drills? Well, they come in a long and a short version. I'm pleased to say that the short version can be used in a lot of other applications where you normally need to use like an extension. You can use the short version and you can minimize the chatter even more. And the other special thing about them is they have internal and external irrigation, both the short and the long. And they have a gun hole in the middle there through the shank of the drill. So there's a gun hole where you can get some internal irrigation, and the gun hole bifurcates into 2 holes lower down, right and left. So you have irrigation right and left towards the apex, and you have the standard external irrigation at the coronal part. Okay, so there's a pilot drill, then there's a 1525. And this is a quad zygoma that I'm doing here. This is the 1525. I'm going counterclockwise through the crest in order to preserve, densify, and expand the crest, and through the zygoma itself, if it's hard enough, I'm going clockwise. So I can change around clockwise, counterclockwise. This is the more mesial zygoma. I'm using the longer drill here. I'm going counterclockwise to preserve the crest, and once I get to the body of the zygoma, I'm going counterclockwise. I'm going clockwise rather, unless it's a very soft zygoma, which does happen. I'm placing a membrane because I've pushed the whole lateral window mesially, so I'm kind of extra sinus but intramaxillary. I've also placed a membrane there. I'm now placing an optimized zygomatic implant. This is the Zygan implant, which has a 3.4 apex, 3.4 and a 4.3, which is a bit thinner than the old zygoma implant. You'll never get two normal zygomas in this particular lady's zygoma. This was a very atrophic zygoma. So we place our implant, once we've placed the two implants, we graft the area with allograft and LPRF, corticocancellous allograft and LPRF. Over the allograft, I place a collagen membrane, and over the collagen membrane, we place LPRF membranes. So there's your two zygomas with the LPRF membrane over the graft. And then we go and do a subcrestal nasal floor lift so that we can place an additional implant in the premaxillary area. We only have about 4 millimeters of bone height there. So what we do is we place our allograft, and then 150 revs per minute clockwise, or rather counterclockwise, we do a nasal subcrestal lift. We then place the implant in this area. So we've optimized this site as well with the Versah. Abutment, one time, healing cap, verify the position. Now we're going to the other side. Again, preserving the cortex, going through to the zygoma, placing the implant, using our surgical guide to get the position of the access hole right. Good primary stability in excess of 45 Newton centimeter. The abutment, one time. Place a wide healing cap. Pilot drill for the second zygoma. That's the pilot denser burr. We've created the final osteotomy. You can see it up in the zygoma there as well. Place the second zygoma. One abutment, one time. Torque the abutment to 45 Newton centimeter. Now we must graft that area with our allograft and place a collagen membrane over that and LPRF membranes over that. So that's your collagen membrane, your LPRF membranes, bite registration, impression taking. This is the impression. This is the bite registration. Laser track, that's a type of articulator, not a full articulator. It's the John Coyce dentofacial analyzer. Patient gets temporaries the same day. That's 7 days later. Patient's quite happy. 2 weeks later. This is another case, a failed case of implants placed elsewhere. Patient came like that. You can see there's very little bone here. In difficult cases like this, I do model surgery and I see what I can do on the 3D printed model. Here we place the zygoma, all on 4 upper. It's 2 zygomas, 2 subnasal implants. This is day 1 with a temporary provisional teeth. Then for the permanent teeth, it's a CAD-CAM fixed screw-retained prosthesis. It's a chrome cobalt CAD-CAM framework cemented on passive abutments with full contoured zirconia crowns. And there is the patient with a permanent teeth 7 days later. And if we have a look at the patient 2 weeks later, this is what she looks like, and 3 months later, this is the picture. And if we do a 3 months post-op CAT scan, we see we have excellent sinus health because we have patent ostia between the sinuses and the nasal cavity. We have no obstruction. That is an absolute requirement. Now, we said that we need to optimize the zygoma at 3 levels. The one was the drills, the one is the implant itself, and the other is the actual procedure. And credit for the procedure goes to Carlos Aparicio, who very nicely in this book of his describes the ZAGA, Z-A-G-A, Zygoma Anatomy Guided Approach to Placement of Implants. He classifies the maxillary zygomatic complex into class 0, 1, 2, 3, and 4, depending on how concave the lateral or anterior sinus wall is, and depending on how in or how out of the maxillary sinus the implant must be. The whole concept is to avoid sinus complications. And I had the honor and privilege to assist him with the very first denser Zaga case, which we did in Barcelona. And it was a Zaga 3 on the one side, which means a little bit of the, or rather, the head of the implant was covered completely with bone and anchored both at the crest and at the zygoma, whereas on the other side, it was basically just in a channel on the crest and in the zygoma anchored. So this is our patient. This is the drill after the pilot drill. You can see that there is an island of bone, which is going to be very useful to protect the head of the implant. Here he is drilling counterclockwise through the crest in order to preserve, expand, and densify the alveolar crest. He wants to preserve that narrow island of bone. And once he gets through the crest and goes into the zygoma, he can change to clockwise in order to drill through the harder zygoma if necessary. On the other hand, he can also drill counterclockwise through the zygoma if the haptic feedback is such that the zygoma is thin. So look how nicely he's preserved that island. I believe that with normal drills he would have lost that island of bone. So this is now the zygoma implant, the Zygan implant, which is a nice implant with a 3.4 millimeter apex and a 4.3 head. So he's now placing the implant. The threaded apical part is going through the crest, and that's the part that's roughened. That's the part that's got a moderate roughness with an SA value of 1.4. That's the part that's going to land up in the zygoma. Then there's a non-threaded section which is not going to be covered with bone. That's going to be extramaxillary. And once we in the zygoma, we now go to the second threaded section, which is machine surface, to have protection against possible peri-implantitis. That's why we say this is an optimized zygomatic implant. It's got rough surface apically, machine surface coronally. So the implant's been placed there. He continues with the zygomatic inserter, 100 Newton centimeter primary stability. One abutment one time. I'm going to fly through this because basically the other side was just creating a channel. I see I have about 2 minutes left. I'm almost there. He places the implant on the other side. This side, unfortunately, is not going to be covered with bone here because that's how this anatomy dictates. It's a Zaga 4 on this side. If that implant had to be placed more palatal in order to be covered with bone, he would have risked having future sinusitis, which is the biggest complication with the classic Zygoma protocol. So with the Zyga protocol, basically you never have sinusitis. You avoid chronic sinusitis, which is the problem with Zygoma implants. And I believe that Zygoma implants will become much more popular and will be used fairly routinely with this new concept that Carlos has come up with. And this is the case, day of op, same day, with the temporaries. This is the post-op scan, and this is Carlos, and I'm honored and privileged to be able to join him in his Zygoma courses, which he's going to be running twice a year. He's been running them for many years, and now he's introducing the denser Zyga drills as from the next course, which is in June. I think the date is 27th, 28th, 29th of June, and certainly in Europe, this is the best Zygomatic course. It involves live surgery, virtual planning. It involves a fresh, frozen cadaver head, a cryopreserved head, which will be scanned with a cone beam. It will be 3D printed. The participants will do the planning on that head, will do the surgery on the 3D printed model, and then we'll do the surgery on the actual frozen head. So it's a course in Europe, in Barcelona, that maybe somebody may be interested in attending. And the next one is in June. And if you want to attend, just go to that website, Press Professionals, Press Course 2019. And on that note, I'd like to conclude that with osseodensification and site-specific implants, it is possible to optimize our treatment protocols, provide less aggressive and less invasive and more accelerated implant therapy to our patients. I'd like to thank you so much for listening to me, and I'd also like to thank these three ladies who always stand behind me and support me in everything I do. Thank you so much for listening to me.